Hello, everybody. I'm Richard Tang-Wai from Loma, previously from Canada, and here I'm talking about IVIG. Just so I can get, it's a small group here, so basically, why are you here to see me? What have you heard about IVIG? Do you know what it is? Oh, sir, go ahead.
So I actually found out about you from Brad Levy.
Yeah.
My daughter's had multiple EEGs from him.
Yeah.
Of a genetic translation. Hasn't been diagnosed with epilepsy, and he said, I think there's actually a huge autoimmune component happening here.
Right.
And he said, you've got to go talk to this guy.
Me? All right.
He's the expert, and IVIG is something very interesting. I'd never heard of it, but
Okay.
when I learned about it, it made a lot of sense to me.
So let's just make sure we're on the same page when we talk about epilepsy. So in your mind, what is epilepsy? Seizures? Spike waves? Sorry? That's correct. Now you have to think a bit more on the cellular level, okay? So we have, in the brain, there's like two major components to it, gray matter, white matter. Seizures are from gray matter. Gray matter is, can you hear me okay? It's a little low. Is this better? Okay, I'll try to speak louder. Is this better? More or less? Okay. Well, you think of seizures as from the brain cells. And just think about seizures from a bunch of brain cells which at the same time fire off at the same time. Okay? Now the big question is, how does that happen? So one thing is maybe the brain cells themselves are abnormal, such that they're overly excited or easily excited, such that they do fire off. And they don't just fire off, they also recruit. So when you have a bunch of brain cells firing off, they recruit other brain cells, and they fire off. And then they recruit other brain cells, and they fire off. Maybe I'm telling a bit about my age here, but did you ever hear about a shampoo commercial called Pert? You know, they tell two friends and so on and so on. That's exactly what happens in epilepsy. You have a bunch of brain cells recruiting other brain cells. Now what does that? One of them, it could be an intrinsic problem of the brain cells themselves, but is there anything else that does that? Okay? So when you think about epilepsy, you should think about something that evolves to epilepsy. That's how I view it. And one of those things, one of those mediators that do that is actually our immune system. Our immune system in the brain is a bit different than the rest of our body. So when you think about the brain, you have brain cells, but then you have these other neighboring cells. They kind of help the brain cells do what they do. One of them is to rewire itself. Basically, when you think about a brain cell, it has a long connection. It's called the axon, and that's represented as white matter. That connects to other brain cells, and then you get a circuit for seizures. So what reinforces that circuit? It's the immune system. So it isn't quite autoimmune in the sense that it's not our own body attacking ourselves like rheumatoid arthritis or lupus. It's actually our immune system forming connections. See what I mean? And in the brain, like you heard about white cells in the rest of our body, they fight infection. Well, in the brain, there's white cells do go in there, but the main thing are these things called microglia. What the heck is that? They're like these neighboring other cells which help the brain cells. And they're involved in like, forming these connections. That's called synaptogenesis. Why? Because when you have two neurons sticking together, that area in between is called a synapse. So they help form those synapses. Okay, so when I give IVIG, the idea is that I'm interrupting that. Because when you have seizures, well, I'm going to take another step back. So how do we learn? We learn by making connections. You think about brain cells interconnecting with each other, it forms a circuit. And if you practice, that circuit gets reinforced. This is sort of in a very basic way. Now, the brain doesn't know, can't tell the difference at the cellular level between a seizure causing a circuit and us learning causing a circuit. See what I mean? So when you have a seizure, one neuron firing off to another neuron, that circuit gets reinforced. What reinforces it? These synapses, these other neighboring cells forming those synapses. At least that's the theory behind it. So what do I do with IVIG? So what's IVIG? These are antibodies. These are antibodies that our body makes. And when they pool them in this little bottle, looks like water, but it's actually full of antibodies, they're pooled from blood donors. Now we don't really know how IVIG works. We do know that it interrupts with the immune system. And the idea here behind IVIG is you're interrupting how those synapses are formed by affecting those other cells called microglia. Does that make sense? So basically what I'm trying to do when I give IVIG, I'm trying to undo that process. Do you see what I mean? Does that answer some of your questions about IVIG? Now, I got involved in IVIG because my specialty is intractable epilepsy. So I deal with kids who have hard to control seizures. They failed a whole bunch of medications. And I had to think about something else, a different mechanism of action altogether. Because when you fail 2 medications, the odds of a third one working are really low. When you fail 3, the odds of the 4th one are extremely low, and so on and so forth. But also you get the side effects, the drowsiness, that kind of stuff. So I had to think about different mechanisms of action, and how I got into IVIG, well, I was desperate, I needed to do something, and I saw it worked. And then I did it again, and it worked again, and so on and so forth. So I did publish my series of kids, and about 30 kids off. I was in the University of Alberta, and I was quite amazed by the success rate. Now, I just have to caution you, this is only 30 kids. And there's some bias there because it's not blinded, but I had an 80% responder rate. Now, what does a responder rate mean? It means 80% of those patients had a 50% or more reduction. And that's what I counted as success. If it was less than 50, I didn't count it. Okay, so just to give you an idea. And what I liked about it was it didn't cause that sedation. It was a totally different mechanism of action, and I was able to pull back on medications. And the reason I wanted to do that was when I treat epilepsy, I'm really targeting quality of life. Usually that goes hand in hand with seizure control, but sometimes it doesn't. So let's imagine you have a kind of epilepsy where you're on 4 medications, and you're having, as baseline, weekly seizures. It's not that I don't try to get 0. I try, but I got to be realistic here, because I don't want my patients to be like a zombie sedated with all these medications. So I try to find this nice balance. And IVIG, I was quite surprised by how effective it had been. And just down south of me, so if you think about Canada and the province of Alberta, I'm from Edmonton, which is northern Alberta, and then down south of us is Calgary, which is southern Alberta. They did a similar study. They also had about an 80% responder rate. Okay? Prior to that, all these studies were case reports, case series, small ones, because that's how you're going to do it. No one's going to say, let me do a study on this. It's out of desperation, you give it a try. The alternative therapy, besides IVIG, is steroids. Okay, so steroids those are the anti-inflammatories. What I found was it can be quite effective, but only in 30% of the patients, as opposed to 80%. And you also had a much higher side effect profile with steroids. You usually get these, big fat depositions, swelling, those kinds of things. Whereas IVIG tended to be really well tolerated, except during the infusion itself. And some patients were sensitive to it so that after the infusion, they would get a bad headache with it. But that was transient, that would go away. I usually give IVIG once a month for 6 months. And the reason for that is when I did my study, I was looking to figure out, when do patients get a response here? When do you say, okay, enough's enough here? Most patients tend to have their best response after the 2nd or 3rd infusion. So that doesn't mean to say there's nothing in the beginning, it trends down, but the best response was at 2 months and 3 months, okay? So I go 6 months because I just wanted to be absolutely sure that I gave it a good shot. I did have 2 patients who did respond after 6 infusions, not after 1 or 2. The fastest response I saw was at 2 weeks after the first infusion. So that's what I do for IVIG. Now, are there any downsides to it? The main problem with IVIG is it's an infusion. You have to come in, they do a peripheral line, so it's in your vein, and they infuse it over a couple of hours. And I do that once a month or so. And I tried to do it in one day. I tried not to space it out in 2 days, just to make it practical and easier. Most patients tolerate it, although some kids, if you go too fast, they get more side effects. You have to spread it out over 2 days, so they just come back a second day. Does that make sense, what I said about IVIG? Do you have any questions about that? Oh. I'm a pediatric epileptologist. It doesn't mean to say it can't work in adults. I just never done it before. And I haven't seen any, not like mine. The reason you're going to see it more in kids is because kids tend to have much more frequent seizures. You tend to hit that endpoint of 4 or 5 medications much faster than adults. And there's a higher level of desperation to try to get better control quickly. So that's why the CBD stuff is, a lot of it's in kids. Any other questions? Oh, sorry. Oh, sorry. You. Yeah.
So, is there a concern with the blood product? Because I understand that it's tested for whatever you know.
Yeah.
What you don't know, you don't know.
That's true.
And it's, I suspect, 60 people in one infusion. How many people for one infusion?
Yeah.
How many people's blood?
I don't know how they, from whom they pull it.
So in my mind, I'm like, is this why IVIG is almost like a last resort? Medicine is the first line of defense.
Oh, I see. I usually do the IVIG after a patient has failed so a couple of medications. So then.
So why don't you do the IVIG first?
So a couple of reasons. One, it's a very foreign concept. So even some of the hematologists don't agree with, well, they can't argue with the results. And there's a body of evidence looking at seizures causing an inflammatory response, but it's not well known yet. The other reason, in Canada as well as the United States, IVIG is extremely expensive. It's several thousands for that vial. Okay, so just imagine there's the cost of the vial, plus you actually go into an infusion center, spend several hours there. It's a bit of a hassle too, to have to drive all the way. So when I present this, there are also very few studies. I mean, one of them is mine, just to give you an idea. That had to come out because, well, of desperation. It wasn't like I had to do something, and since I've been doing this in patients anyways, there are some questions to ask. You know, how effective is it? Is it just me looking? You know, sometimes when you're too focused, and you may think it's a success, but it really isn't.
Do you get concerned about what may be in the blood?
To some degree, yes. But the way I look at it, so the average patient who I put on had multiple daily seizures on multiple medications. They weren't surgical, and I had to do something. And at that time, Canada still doesn't have Epidiolex. So we only had the oils, and even then the results were kind of iffy. I had to do something. So in my mind, it justified the risk. And knock on wood, that study was 2017. That took almost 3 years to do. Those patients, knock on wood, so far so good. In terms of further risk, they do, because of the hepatitis and HIV infections, they do screen these blood products much more rigorously than they did in the 1980s. Oh, sorry, he's next than you.
What was the research that indicated immunoglobulins could potentially help?
It was a fluke. So in the 1970s, I was trying to find out, like, how would you think about IVIG? And there was a patient, got IVIG for another reason, but also had intractable epilepsy, and it was one patient, and they seemed to do well in terms of their seizures. And then, it's like anything else. You get desperate. Well, there's that guy who did it. Why don't I give it a try? We got nothing to lose, and so on and so forth. And then that's how it happened with me. But then when I started noticing this success rate, I kept doing that.
Has there then been further research to analyze, what is the biological pathway?
Right.
Why is it doing what?
So So even for autoimmune disorders, you ask an immunologist, how does IVIG work? They can't give you a definite one mechanism answer. They'll say, short answer, we don't know, but here are a whole bunch of theories behind it. I don't have it. I have actually a graph on how it could work on different levels. But so it can work on, so I have to, it's a long story. It's a long story. So when they looked at temporal lobe epilepsy in adults, okay? So that's the most common form of epilepsy in adults. So it's epilepsy in the temporal lobe on, right here on the side. What they found when they did surgery, so they cut it out, they looked under a microscope, they saw an inflammatory change there. So that led people to think, okay, there must be some degree of inflammation for intractable epilepsy. So there is a body of evidence suggesting that that's what happens. So it's not just microglia getting activated, it's also T cells from the periphery entering the brain. IVIG works on the T cells. It could, and somehow works on the microglia itself. How exactly? I think the reason we don't have one specific mechanism is because there isn't one. There's probably a whole bunch of them, they work together. Short answer there. But oh, sorry. Oh, you next, and then you.
So you do the treatment for 6 months. What
That's right.
happens after the 6 months? Is the child or is the person no longer having any seizures?
So some did. Some were completely seizure-free after the 6 months. And that was a big question I still have is who can I stop it? And whom can I stop it? Because some kids I could stop it and they remain seizure-free. Other kids, you stop it, they remain seizure-free, then seizures start to emerge again, and then they come back after a couple months, so then I restarted it. But then when I restart it, I'm afraid to stop it. So some of these kids, I had to keep going for a long period of time. Canada, it's not an issue. We have free health care. It's covered. I could do that.
What kind
But
of side effects do they have?
so it's usually from the infusion itself. That's the most common one. So what happens is when you get IVIG, they infuse it at a slow rate because some kids don't tolerate it. They get a fever, they may get a rash. Most of the time it's fever, they feel unwell, and you treat that with Benadryl. It's not quite an allergic reaction, but we give Benadryl for that. Afterwards, the main side effect that I did see in my patients, if they got it, were headaches, especially if they had a history of migraines. They tend to have these really severe migraines. So what I'd have to do is I reduce the rate. Long term, I mean, the longest I had a patient on for 13 months, still ongoing. I left, so I don't know anymore, but tolerated just fine. Now, if you Google IVIG, one side effect that they'll comment on is something called hyperviscosity syndrome. Something that's viscous means it's thick. The idea is when you give a lot of antibodies, which are proteins, it thickens the blood. So the idea is that maybe it could sludge the blood. I haven't seen that, and it hasn't really been, although it's been reported, it's not something commonly seen. So for epilepsy, we don't use it that often, but for other autoimmune diseases, they use it quite often. Some go through it monthly, just to give you an idea of how extensive it's used outside epilepsy. As far as I know, in Edmonton, there wasn't a case of hyperviscosity, but it's always a risk factor. It's always something you got to think about. I think, who was next?
Just wondering the
Sure.
age range that you
I did it in all kids. I did it all kids. Youngest was, I think, 10 months. I was desperate, had to do something. I'm sorry.
So, creates sludge in the blood.
Oh, hyperviscosity syndrome. It doesn't mean it will, that's something that they mention.
And is that something that can lead to blood clotting?
Yes, yeah. So the idea is you get all this protein in your blood, it thickens the blood and then slows things down in a nutshell. Yeah.
Did those children come off of their AEDs?
Two patients did. Most patients we were able to cut down. Most patients did not go off all of them. But 2 patients I was lucky to be able to do that. Any other questions? Yeah.
If you have multiple
Okay.
Is it possible that multiple disorders can be linked to
Yeah.
seizures?
Short answer is when they did a population study on autoimmune disorders of various kinds, from Crohn's to lupus and all that, they did find that more of those patients tended to have epilepsy than the general population. So not quite clear why. The way I look at the immune system for epilepsy, you should think about it as the immune system is always there. It's always working. That's how we learn. That's how the connections in our brain get formed. Except with seizures, you have an aberrant circuit, if you will, that's firing off uncontrollably. But it's the same mechanisms that form those synapses that help form the synapses or the connections of how we learn. And that's how you should think about neuroinflammation. You shouldn't think of it like necessarily an autoimmune disorder. But there are autoimmune disorders of the brain. And the reason I say that is they don't behave the same way. Okay? One example is something called Rasmussen's encephalitis. Okay? Sorry. Yeah.
My son's starting IVIG next week.
Okay.
He has encephalopathic CSWS.
Okay. Yes. Continuous spike wave. Yeah.
And one thing that's interesting is I've been told that while the ESES might not come under control with the IVIG, he still might have behavior and learning improvements.
Okay. How does ESES do that? We don't quite know, to be frank with you. The idea, we usually lump them together as something called an epileptic encephalopathy. It's a long-winded way of saying you have a problem with how your brain works from a lot of seizures. But in ESES, it's not so much seizures, it's the spiking. The spike, so you don't see any clinical seizures, you'll see electrographic seizures on EEG. And that's what causes the problems of intellectual decline. How does it do that? We're not sure. Is it strictly that the neurons are firing and overwhelming everything? That's one thing. But also, when you think about how the immune system works, don't think about the immune system as always being there only when there's affection or injury. It's always working. So even if you have a neuron that's working aberrantly or abnormally, that innate immune system kicks up. I used the term, innate immune system is the microglia. That's the immune system that's in our brain. That's what gets activated here, okay? So just imagine now you're reinforcing a circuitry that shouldn't be reinforced. See what I mean? Now, ESES, usually that affects these areas right there. That's the language center on the left side. So what happens, I don't know your son's case, but generalized? Okay. So usually with those kinds, I don't mean to comment, but just in general, those children who have it all over as opposed to more focal, tend to have a more global regression. So they tend to go down, they even call it an autistic regression because they start to have these autistic features. Some of them are more restricted to the temporal lobes. Your son? Yeah, that's called they used to call Landau-Kleffner. Okay. So, yeah. So what I tend to do personally, so steroids has a 30% responder rate, but it's much faster. So in my series of kids, I saw the best response was at 2 weeks, and I was consistent among the few kids who did respond there. And IVIG took 2 months, 3 months, so I usually do the steroids IVIG because I can't wait I like things fast. So I sometimes do that so try to do something faster. It may or may not work, but it buys me time for IVIG to kick in. That's just another strategy there. Yeah.
Is it covered by insurance? And then do you have to go to a center, or do they come to your home and infuse you there?
We're doing it at CHL. And I think
Yeah.
another question I
Yeah.
wanted to ask was, because we're about to go in,
Yeah.
Jason doesn't communicate, everyone communicates, but he can't speak, he doesn't
Right.
use a talker or sign
Right.
or anything. And it's hard to know when he's not feeling good, what's wrong. He can't
Yeah.
tell us, like, I have a headache. He often doesn't get a
Really?
I'm
Okay.
worried about being able to know that he's having these side effects, and I want to know what we can do to help prevent and mitigate. Like,
Okay.
I think it's already going to be really slow because he's going in for 2 days,
Yeah.
8 hours.
Usually the first day is usually really slow because they start at a very slow rate and they follow, every center has some kind of protocol and they just gradually increase it. Sometimes what you can do, you can pre-treat with Benadryl and Tylenol. That can sometimes help the infusion reaction there. And then they find out what the maximum rate is, and that, pretty much determines how much you can anticipate staying for the next couple of infusions. Some centers give 2 grams per kilo. I give 1 gram per kilo. We don't really know the dosing. We just know you have to give a massive amount. And how much massive is it? We're not quite sure. 2 grams per kilo, I haven't. Again, 1 gram per kilo I found pretty effective. In the other case reports, they went as low as 0.4 milligrams per kilo. So 0.4 grams per kilo. So just to give you an idea, there is a range there. So if you didn't tolerate 2 grams, because if it's 2 days, that's usually a 2 gram per kilo. I'm not sure, but that's what it sounds like to me. Yeah. Any other questions? Yeah.
Right, I have a son who's had almost a clean EEG,
Okay.
MRI. He has like West Coast lab tests,
Okay.
ADHD, some autism,
Okay.
very verbal,
Yeah.
and a suspicion. And when he does start to have these episodes, he'll repeat the same word, like I don't wanna, and have like scratch his entire body
Okay.
down to the core in the night.
Wow.
And
Okay.
doesn't even remember like the
Yeah.
episode. So some of the thought came up about some of the Taka doctors that I showed some video to, saying
Yeah.
autoimmune encephalitis is what it kind of looked like.
Okay.
And he's on Trileptal, but
Okay.
it doesn't seem to be
Working?
working.
Yeah.
And he goes to these episodes and he'll start to say, there's a couple voices that are telling me to do stuff.
I understand.
And he'll go, does this sound?
So,
Yeah,
so IVIG can be used for autoimmune encephalitis. Okay.
sorry, what?
So IVIG can be used for autoimmune encephalitis. The chronic epilepsy, I want to make it very clear, is not like an autoimmune encephalitis. Okay, it's not actively your body's attacking your brain, which is the case of autoimmune encephalitis. Okay, it behaves differently. So there is a common link between the two, and that's the immune system. So can IVIG work for that? Yes, it can. Okay. Is it easy to treat autoimmune encephalitis? Sometimes it's extremely difficult. Sometimes it's usually steroids, IVIG, and they try something else besides that. Depends on how certain they are of the diagnosis. Because when you start to ratchet up the different kinds of immunotherapy, there are different kinds of side effects there too. I presume they did an autoimmune panel and all that?
We haven't done that yet, but
Okay.
he's a patient of Dr. Harani and
Okay.
all the low-dose immune therapies and
Oh.
things like that, like Dr. Ty Vincent.
Okay.
That's been extremely successful
Okay.
for him, but I do notice like it's just gotten weird and it'll go through bouts where I'm like, oh my god, my kid's schizophrenic.
Okay.
And it's just that, but then he's fine. He's like, oh, I'm not
Okay.
having voices. And I noticed another
Yeah.
doctor told me to do Benadryl.
Benadryl? Okay.
And ibuprofen when he started to, and it like stopped him from
Okay.
like a 3-hour episode.
Huh.
So he ran out of the house, and he ran out of the house to like run into traffic, and he didn't even remember. Which didn't seem, it only was during this episode. I mean, he's in
Yeah.
typical school. Does that sound like inflammation?
No, well, it's not specific, right? It's not specific for any particular disorder, I'll be frank with you. Did they do EEG monitoring on your son?
They did, Bradley, we did it
Okay.
at home, but then he can't have the anesthesia. He has a G mutation, and THFR.
Okay, gotcha. All right.
Yeah, it's just,
Yeah.
I'm just trying to ask you because it seems like everybody's talking autoimmune, and I know he does have a West Coast line
Okay.
positive test that has come out and he's been treated when
Yeah.
with the strep
Yeah.
So it just seems to be, I don't know
I understand. Yeah.
I don't know if that's necessarily like what he needs to be doing.
So
So, I don't know, just as an autoimmune expert,
Yeah.
I just wanted to ask.
So you need something to really hang your hat on to call it autoimmune, like either some kind of marker of inflammation or some kind of autoimmune antibody that you can follow to be. Some people have done it, just because they ran out of options, yes, but you're never certain, Short answer is I'm not sure what's wrong with your son, Sorry. Yeah.
Thank you, Dr.
No problem. And start.
When you were talking about the neurons being abnormal,
Yeah.
you're saying that relates to an autoimmune effect?
No, not autoimmune. So when our brain functions, okay, how our brain cells work, the immune system is always involved. Not in an autoimmune way, meaning it's attacking. It's actually trying to help the brain cells work normally. That's how it forms the connections. You see what I mean? So you can think of, we call this term neuroinflammation, but usually when you think about it, you think of it as an abnormal response. I'm trying to argue that it's not an abnormal response. It's always there, except in epilepsy's case, it's an abnormal bunch of neurons using the same mechanisms, which is this neuroinflammation. You see what I mean? Does that make sense?
Yeah, I'm just trying to relate it to our case. So my
Okay.
son has a genetic epilepsy.
Okay.
So there's a problem with the sodium.
Sodium channel? Okay.
So how does that relate to this type of treatment? It doesn't.
So in my series of kids, I think it was, I forget, a good chunk of them were genetic causes. So some of them were Dravet's. The Dravet, I had 2 Dravet patients. They did really well in my series of kids. And then I had a variety of other genetic mutations. And they seemed to respond. What that tells me is that this neuroinflammatory process is, it's involved in all kinds of epilepsy, whether it's, so I had kids with brain tumors who seem to respond to it, and actual malformations who seem to respond to it. So that neuroinflammatory part seems to be a common link for all these kinds of epilepsies. So I wasn't expecting to see that actually, but it seemed to work. So the short answer is, when you think about neuroinflammation as a normal response, so then any kind of epileptic activity can trigger a neuroinflammatory response. You see what I mean? Does that make sense?
Yeah, it makes sense.
Okay.
But and then you can't measure that.
No, we don't know how to. So we are trying different ways of imaging the brain. We, meaning myself, and it's at Loma Linda. We haven't gotten off the ground, so there's nothing to report. But we're trying to find markers for neuroinflammations that we could image, Yeah. Oh, sir.
With a negative EEG,
Yeah.
is the MEG helpful?
MEG? MEG? So MEG is what's that? Magneto. I'm having a brain moment here. It's so instead of EEG looking at electrical activity, you look at magnetic fields. So when you think about brain neurons firing off, they discharge, they create an electrical field, that creates a magnetic field. MEG tries to find the source of the epilepsy looking at magnetic fields instead of electrical fields, okay? So it's really useful for deep things that you can't see on an EEG. It really localizes things well. The problem with MEG is you pick and choose the spike you want to localize. So let's say you don't know where the epilepsy is, okay? And then you have a whole bunch of different spikes in your EEG, and you pick one of them. It'll pick out that spike really well. But the ultimate question for a guy like me who wants to find out where the seizure occurs, you won't be able to determine that, because you're actually, it's like a self-fulfilling prophecy. You're picking a spot for the MEG to analyze. You see what I mean? That's the problem with MEG, okay? Does that make sense? Any other questions for me?
So is MEG a second step to the
Yes.
EEG?
Yeah, well, it's usually a third. Not every center has a MEG. So usually it's EEG, and depending on what your hypothesis is, and if you can localize the seizures from the EEG, you may have to do other things. So it's PET scan usually, SPECT scan, so PET scan looks at how the brain metabolizes certain things, in this case glucose. The idea being that the areas of the brain which are causing seizures tend to use up more energy, therefore there's more glucose being used there. And that's one way to localize it. SPECT is looking at blood flow. So the same idea, area causing seizures, there's an increased blood flow there. So you're looking at that, okay? MEG is a couple ways down. Like I said, because you're picking and choosing the spike you want, like you really want something that, independent of all that, will tell you where the epilepsy is coming from.
But if you find nothing in all of
Yeah.
the three,
Then you go to MEG, yes. Yeah, not every center has a MEG though. It's only just a couple centers. Tough to do it in kids because sometimes you have to sedate them for that. Yeah.
do your children also have to be sedated when they're getting the IV?
No, most kids tolerate it really well. Usually the parents with them.
If you have an SIV child, I mean,
SIV, sorry.
Self-injury.
self-injury
Oh.
behavior.
I haven't had a problem. Often when you give the Benadryl, you pre-treat Benadryl, they fall asleep with that. So that wasn't the purpose of giving it, wasn't to sedate them. I've had kids with Rett's who went through it. But usually the mom or the dad's there and they're able to calm their child down. And usually the nursing staff at the infusion center are real good pros at this. And so far, knock on wood, I don't like sedating kids if I don't need to. But so far, so good.
I have another question
Sure.
regarding the steroids.
Yeah.
The steroid treatment is, are there side effects to that? If there's diabetes in the family,
Okay.
is that a factor of whether or not you would give a steroid treatment?
You just have to be careful of blood sugar. If it's a family history of diabetes, but the patient doesn't have diabetes, you're probably okay. But you probably want to check the blood sugar and adjust your insulin from that. I haven't done insulin management in a long, long time. Usually it's a sliding scale that they use, What I usually do when I had one patient who needed it, I talk to the endocrinologist. I say, listen, I'm going to put this patient on steroids. Can you help me out here? Just because it's out of my territory there. Yeah. Does that answer your question? Any other questions? Oh, ma'am.
I was gonna ask about if the seizures are coming, they're really deep.
Yeah.
And B, coming from multiple spots. Like they could start from the left, they could start from the right.
Right.
and they could-
Yeah.
Would that fall in the autoimmune area, or they?
Not necessarily, no. Sometimes you just have kids who, for whatever reason, they just have this entire epileptic network, just a whole bunch of neurons interconnecting, and sometimes it starts on one end of the network, sometimes it starts at the other end. It doesn't necessarily mean autoimmune. That being said, though, when they looked at some of these supposed autoimmune epilepsies, like something called FIRES and something called NORSE, these are certain kinds of epileptic syndromes. They tend to be multifocal in different sites. So, short answer, yeah. Ma'am?
Do most of the kids that you treat, do they have just epilepsy or do they have multiple disabilities?
They usually have multiple. Well, the epilepsy is the primary one. Like, for example, I had children with Rett's who have, of course, they have the epilepsy, they have the developmental regression, and so on. Some of them had, because they had a stroke and they had IVIG, they had the cerebral palsy with it. So but I was treating primarily epilepsy.
Brain tumors?
Yes, brain tumors too. Yeah.
Is that part of autoimmune?
No.
My daughter has
No.
autism, epilepsy,
Yeah.
and then developed a brain tumor.
So it's not, but tumors do trigger a neuroinflammatory response. Like these cells that are in our brain, the microglia, are sort of monitoring the brain for anything. They react to it, whether it's aberrant neuronal action, like a seizure, or from any insult to the brain, like a tumor or a stroke or anything like that. So there is a neuroinflammatory component there. It doesn't cause it, but there is an inflammatory response to it. Does that make sense?
Actually, I should have listened closer to the beginning.
Oh, that's
So
okay.
So are you saying the epilepsy could be causing like damage to the brain?
Epilepsy? It causes,
Or the seizures could be causing the damage to the brain that could cause the weird, because she had not just the tumor taken out, she had areas in her brain that were also abnormal.
okay,
taken out, and it was
okay,
deep.
I see. So,
But that probably happened. Does one cause the other, I guess is what I'm trying to say?
so does the seizures cause the tumor? Is that?
Yeah.
No, short answer is no. Short answer is no. Can you have a seizure causing sort of this aberrant network forming? Yes, you can. But not a tumor or malformation, okay? Any other questions, ma'am?
You said that you treated with this treatment for the brain malformation?
Yeah.
What type of brain malformation?
Cortical dysplasia, hemimegaencephaly, I forget.
And that was what was causing their seizures?
Yes,
And there was success with that?
yes, yeah.
But was there regrowth or, I don't know?
So dysplasia just means abnormal brain formation. So they're not tumors. It's not like a abnormal mass growing. It's just the brain cells, for whatever reason, were not normal. But they don't worsen with time. They just stay like that, but they function abnormally. Yeah.
And you said microcephaly?
Oh, no, hemimegalencephaly, yeah. If you're interested, it's in Seizure. My article's in Seizure 2017. So, any other questions, sir?
Can you talk a little bit about deep brain stimulation and ECT?
Okay, I don't know a lot about deep brain stimulation. Short answer is, how does it work? We're not sure. ECT, I definitely can't answer there. ECT, so electroconvulsive therapy, I can't answer that at all. I only had one experience with it, and that was a patient in status. It didn't work. So let's take deep brain stimulation, okay? How does it work? The short answer is we're not sure. The idea behind it is that seizures come from the periphery, the cortex, but there's a circuit going deeper, okay? So it's the brain, so just imagine on the cortex, a seizure starts, it goes deeper, and then spreads. So the idea behind the deep brain stimulator is it interferes with that circuitry, okay? The other thing about the deep brain stimulator, so just to take a step back, deep brain stimulation means stimulating deep in the brain, thalamus, basal ganglia, okay? Because there's a circuit first there's those structures reach outwards to kind of quiet down or excite. And the idea behind a deep brain stimulator is to artificially do that. That's a theory, we don't know, okay? Electroconvulsive therapy, you're actually causing a seizure to stop a seizure. I don't know much about that, to be frank with you. Okay.
Do you know where they might be doing the deep brains in the country?
They're doing it but for adults. They mainly do it for adults. Is it approved for kids yet? It wasn't. At least it wasn't in Canada. I don't know about the US. I just got here a year ago. Yeah, thank you. Yeah. Yeah. Any other questions? Yeah. Are we done? I have to, okay. Any other questions? You got me for another 5 minutes? Hey, no problem.
Adam. These are my in-laws.
Hi. Pleasure meeting all of you, by the way.
Thank you.
Okay.
That was great.
Oh, thank you.
So Brad says you're a guy who loves a challenge.
Well,